Good evening, everyone. A very warm welcome to today's session on strengthening lung cancer care pathways, clinical outcomes, population impact, and policy reform. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my pleasure to welcome you all today. This session is an initiative by Voice of Healthcare and is supported by AMNEED. Today, we bring together a distinguished panel of experts to discuss a critical, evolving challenge: how we move beyond advances in treatment to ensure those advancements translate into real world patient outcomes through stronger system, better coordination, and enabling policies. As India continues to advance in lung cancer diagnosis and treatment, we are now at a critical inflection point. Today, many patients still face delay at multiple stages, whether it is early diagnosis, accurate staging, or timely initiation and completion of treatment. These delays are often not due to the lack of clinical expertise, but rather due to fragmented care pathways, weak referral linkage, infrastructural gaps, and limited system level coordination. In addition, disparities in access, affordability challenge, and variation in care delivery models further impact patient outcome, especially when we look at population level impact. This brings us to core focus of today's session. How do we move from isolated clinical excellence to more integrated system-driven approach? With this context, let me introduce our esteemed panelist, Dr. Tejinder Singh, medical oncologist, Apollo Hospital, Mumbai. Welcome to the session, Dr. Tejinder.
Thank you. Thank you, Vaishnavi, and your team of VOH for inviting me for this panel discussion.
Thank you so much, sir. Dr. Seema Devi, consultant radiation oncologist, IGIMS Patna. Welcome to the session, Dr. Seema.
Thank you. Thank you.
Dr. Preetam Kumar Jain, medical oncologist, 𝗟𝘁𝗵𝗲𝗁 Hospital, Mumbai. Welcome to the session, Dr. Preetam.
Thank you. Thank you so much. It's my pleasure.
Thank you. Dr. Satish Sharma, Senior Consultant Medical Oncologist, Manipal Hospitals. Welcome to the session, Dr. Satish.
Thank you and good evening to everyone.
Thank you. Dr. Divya Singh, Senior Manager, Monitoring, Evaluation and Reporting, 𝗟𝘂𝘗𝗏 Foundation. Welcome to the session, Dr. Divya.
Thank you, Vaishnavi, and thank you for having me here. Glad to be being a part of this esteemed panelist.
So thank you so much. I think with that context setting, we'll straight away jump to the agenda of today's session, where we will be talking about lung cancer and strengthening the care pathway system. So my first question is to you, Dr. Tejinder, that at which stage, diagnosis, staging, or treatment initiation do you see the most critical delay, and what systemic factors contribute to this gap?
So I think in lung cancer, important thing to understand is that there are three important aspects of when we see any patient. One is a diagnosis, and the most important is proper diagnosis. Next level is the stage, and last is treatment initiation. So I think all three aspect the delays happen. Delays happen either in the diagnosis because many of these patients they'll be treated like a infection. Staging comes only when we get the diagnosis, and lastly is the treatment initiation. So I think the bottleneck is still in India when we have confirmed diagnosis to when we start on the treatment. So we are still facing the challenge in this. So I think all three aspects are important, but the bottleneck is still the treatment initiation from the diagnosis. I think the why the bottleneck happen is because of one important reason is the cost. Second is we have a lot of inhibition in our mind that what will be the treatment, how we call it awareness. especially awareness from the primary care to the specialist referral also. So I think a delay happens because of multiple factors apart from the cost. Still, awareness needs to be created that not every lesion which is sitting in the lung is infection. It has to be. It can be a lung cancer, and that is very important point which needs to be kept in mind. But like I said, what happens is that uh, delay happens because there are people who are taking multiple decisions, trying to wait for the slots, and we sometimes nowadays have something known as molecular testing. It also delays the treatment aspect. But day by day things are improving in India. I think we are becoming much better in the cities. The problem, I think, is in the rural area and smaller places where it's still a challenge to get a proper diagnosis and to start or initiate the treatment. I think that is one area which we need to improve. Government has done a lot by way of cost wise. Now there are so many schemes are there which are getting covered. I think our reach has improved a lot after the a lot of yojanas which have come into place.
Correct. And I think as we move forward in the session, we will be speaking more on how we can maybe overcome this gap which is there in the tier two and tier three cities. So I look forward to having these discussions forward in the session today. So my next question is to you, Dr. Seema, that radiation therapy is highly time sensitive. So, what are the most common clinical or logistical response patients are unable to start or complete their treatment or on time or as per their schedule? Ma'am, I request you to
Request.
please unmute. Yeah, you're
Hello.
now audible. Yes, yes.
Yeah. So most of the time, patients are not aware of the importance of treatment, what they require, what they should get. And the second part is financial burden. Patient has to travel a lot and arrange their accommodation and food, etc. So they are reluctant to come to the city and arrange the money to come and start their treatment. So these two basic factors are most important in our area. But the treatment facilities, as the Dr. Tejinder said, so many government schemes are started. So most of the treatment is free with government help, and the other NGOs are working. But the infrastructure is not supported so much by the government to take care of the all the patients who require treatment for the next 1.5 months. So where they stay, where they take the food, and they are able to they should feel the safe to that area. And the third thing is side effects and myths about the treatment. Due to ignorance of the treatment, and they don't know the detail of the treatment, they thought the patient will die due to complication and side effect. So these are the factors we face day to day life.
Correct. I mean, if you can maybe give some real life example to illustrate that, because I think radiation therapy is one of the most relevant and one of the most prevalent treatment option that we see. So, have you seen any such case on any such patient where not sticking to the schedule has been a problem for a complication?
Yes, many patients face their financial burden, and they don't have to arrange, they are not able to arrange the money to stay at the city to receive full treatment. And they start treatment, and after getting 5 fraction or 15 fraction, they get away due to financial burden, and then came back to progression of disease after 1.5 month with the arrangement of money. And so some social issues are there, some marriages there, so they want to entertain everything regard less than the treatment. So
Correct.
these are the factors. Patient came, but they don't want to complete this type of 1.5 months with explanation of so many problems, with problems, not very big issue. They don't know the importance of treatment. How should they complete the treatment and what the benefit they will get after the treatment, about the disease, about the seriousness of disease, about the sickness, about the side effect of the disease. So these are the factors they face day to day life, and they are reluctant to stay
Correct. So I think with that context setting, since we are talking about the delay in treatment and delay in diagnosis that we see, I would like to take my next question to you, Dr. Preetam, that in institutional systems, what recurring patterns do you observe in delayed diagnosis or treatment drop-offs, and what do they indicate? Dr. Preetam, are we audible to you?
Audible? Hello.
Yes, yes, we can hear you now.
Yes. So if you see in our country, India, the outcomes in lung cancer.
Dr. Preetam, I think there is some network issue at your end since we are facing a lag. We can't hear you.
I can hear you very clearly.
Yeah, now you are audible. I think we lost you in between. So you can start. Yeah.
Yeah. Yeah, okay. Thank you so much. So I was like about to say that, in our country, I mean, the outcomes in
Um, Sir, are you there?
hello.
Yeah, I think there is some problem when you're starting. We are losing you there. You are now audible
I'm
to
so sorry,
us.
but I can hear you very clearly.
I think, yeah, you can continue now. I don't know. Now you are audible to us. I just request you that if
Okay,
there is
thank
some,
you.
just don't change the screen. Maybe that is the issue. Yeah.
So what I'm trying to emphasize over here is that see, the entire world is celebrating how oncology care is evolving. But in India, it's important that we create a system. The system needs a very important strengthening of the coordination with effective communication and the continuity of the cancer care. And it's important that the patient enters into the system very quickly at an early stage and has a very smooth journey throughout the entire treatment spectrum. And a lot of factors have already been mentioned that we see this pattern of delayed diagnosis and drop-offs consistently across all the institutions in our country. And the factors are multifactorial, right from the delayed referrals, delayed diagnosis. Diagnosing lung cancer sometimes gets complicated when they don't present in a very straightforward fashion. And since there is a fragmented healthcare, patient needs to undergo staging across, the diagnosis with various scans, biopsy. Earlier, we used to start chemotherapy, but right now we have to wait for the molecular testing patterns also to understand for the personalized therapy. Then comes the treatment plan, where a lot of factors, takes into consideration apart from the chemotherapy myths that the patients carries and the fear that they carry within themselves, a lot of social influencing factors plays a major role in their decision making, like what the neighbor says, what the family member says, and what the community at large and the previous patient experience also matters a lot. I mean, we keep telling to our patients that every patient journey is different, every cancer is different, and every patient responds differently. So it's important not to get influenced by such social factors. So these are the things that we come across into our daily practice, and certainly right now we are in a better stage in a cosmopolitan cities, in our tier 1 cities, but in the rural areas it's still fragmented with the delayed referrals.
Correct. So I think I'll take my next question to you, Dr. Satish. So, as per your understanding, where do you see the biggest gap between the ideal treatment plans and the real world execution, and what drives this disconnect?
So there, suppose you talk about a metro city, probably the cost is not an issue. But then when you talk about places like second tier or third tier city, the 80%, 70 to 80% of the crowd, they take treatment under Ayushman Bharat. So suppose a lung cancer patient, the standard of care is in stage 4, we have to do an NGS, and we have to start some target therapy or immunotherapy. So not everyone is affording for that kind of treatment. And then Ayushman doesn't cover at all the newer tests or the newer therapies. So one is of course, the finance is the issue. Second is awareness. A lot of places in second or third tier cities still get treated for tuberculosis. So we have seen patient taking ADT for 6 months or 1 year, and then they come to us. So awareness among the patients, awareness among the general GPs is still low about the lung cancer, and we know that with the government directed policies, we had a good control over at least tuberculosis. The third thing I'll say, the logistic issues. So not everyone in places like Jharkhand or Bihar, like we have only 2 or 3 centers in a state where patient can take treatment. Bihar, I think only Muzaffarpur and Patna, only 2 centers are there. So somebody who is living here in my city, in Ranchi, almost I practice in Tata and Manipal hospitals. So both have different kinds of problem. Like people who are coming to Manipal, they are TPA patients, cash patients. So their problem is their children's, because they have been living either in US, foreign countries, or in metro cities. So they are generally accompanied by their servants, caretakers. So there is nobody who makes sure that they come on time. So whatever their caretaker says, or whatever understanding they have, they'll come on their time. And of course, a blood relative, if it happens to be with them, it will be better for the treatment adherence. Whereas in Ayushman Bharat, so we have places who's somebody who's traveling from say 200 or 300 kilometers. We have patients who are traveling from like 400, 500 kilometers to us. So the cost issue of travel, the stay, because we don't get Ayushman approval in one day, so that becomes enormous. So if I have to summarize, there is a logistic issue because the cancer care is not at the periphery. There is social issues where even somebody who is affording rich, they don't have attendants to take care of them. Then there is finances where somebody is affording, but majority of our lung cancer patients, they are not very much affording, and they have very poor support from the government side, so that a doctor can give a standard of care to them.
Correct. I think that is very well stated. I will take my next question to you, Dr. Divya, that at which point in the patient journey is data capture weakest, and how does this limit effective monitoring and decision making?
So the biggest blind spot tends to emerge right after a patient is identified as high risk or symptomatic. And that transition from suspicion to confirmed diagnosis and then into treatment is where visibility drops significantly. So at the front end, awareness screening activities, these are fairly well documented. But beyond that, systems struggle to consistently track whether a patient actually completed diagnostics, whether they got tested, or if they initiated treatment at all. So because there are multiple facilities involved in the care pathway, the lack of continuity in this data makes it difficult to understand real outcomes. And we end up measuring, say, activity rather than impact, which limits our ability to identify delays, drop offs, and system inefficiencies. So, we need to strengthen end to end patient tracking, particularly across providers, and if we want this data to be truly supportive in decision making.
Correct. I think with that, we would head towards the next segment of our discussion, and I'll take my next question to you, Dr. Tejinder. That what is the single biggest barrier preventing patients from reaching specialized oncology care in time, and how it is addressed at scale?
So I think one thing we need to understand is there are a lot of barriers. We talk about the awareness, we talk about the place where we are sitting, we do talk about the technology, but I think there's no single factor which is a dominant factor. It varies from geographic to geographic area. Many big issue happen because a right place to refer should be kept in mind. We have primary care physicians. Our drawback in oncology is that the in an MBBS course we do not have that much training for oncology. So oncology training is quite missing from the most of the curriculum, and that's the reason why tendency to fail recognizing cancer symptoms is very common. So I think that's an important point which we need to understand. A right time of referral from the primary care physicians, and understanding that this problem is something we need to address it. But barriers apart from the barrier is a feeling that treatment is very costly. Treatment is going to create a simple answer that since it is a cancer, then the probability of survival not being there is there. So I'll just give you one example. One example of my patient around 20 years back when I started practice. So he had a very simple. He came to me in a stage 4 disease. Like lung cancer normally presents in stage 4 commonly. Around I do see around 80% of the patient who will come in stage 4. Around 15% in stage 3 and 5% only in stage 1. So this boy, basically a young boy of around 28-year-old, he had cough, he had bleeding from the sputum, and he was diagnosed as TB for almost 5 months. Given treatment with anti-tuberculosis by a physician, and when the fever was not subsiding, they had done a lot of investigation. So 5 month delay is a big delay because people have a tendency to say that young people do not get lung cancer. So 5 month delay, ultimately the disease went to the brain. So that becomes like a very big issue because and ultimately it was thought that the brain lesion, whatever are there, are also TB. Getting treatment for TB almost for 5 6 months. Then some good sense prevailed, and somebody did a biopsy, and the biopsy showed lung cancer. So the family took nearly a week or 10 days to understand that it is a cancer. Right diagnosis has come. We need to look into the treatment for cancer. This boy has been living for the uh, I say around, he lived for nearly last approximately 12 years with only a tablet. And later on, he had some other issues which created a problem, and he could not survive. Not He never died because of the disease, he died because of something else. So I think the awareness has to come not only from the point, the barrier is not only awareness, barrier is that our mindset also, not only from the clinician side, from the family side, from the hospital side, that there is always a way out for everything in life, and there are always a good treatment option for everything. Yes, if we do it quite early, the survival is very good. So yes, the barrier challenge is always there. There is no one barrier which creates an issue. There are multiple barriers. You cannot pinpoint on one barrier. But I think things have changed a lot in the last decade, uh, we have medical oncologists sitting here. All of them are there. We can see a difference in the lung cancer. Around 20 years back, we used to always say the option of was only chemotherapy. So now we have so many new drugs which have come, which improve the survival with excellent quality of life.
Correct. I think that's very insightful and very inspirational also for all of us who are here on the panel and also for the listeners who are listening to this session. My next question is to you, Dr. Seema, that how can radiation services be expanded across regions while maintaining quality, especially in resource constrained settings?
Actually, radiation facility is so costly, so government should take the initiative to start the radiation therapy machine. Cancer patient will require one teletherapy machine. So that criteria we don't fulfill this criteria. So government should take the initiative because this is very costly. 25 to 30 lakhs per patient.
Dr. Seema, you are not audible to us.
Why?
Now you are. We lost you in between, actually. I think there is some network issue at your end.
Okay. Now
Yes,
you are
yes.
getting
Yes,
voice.
it's better. Yeah, you
So
can continue.
what I said that radiation machine, every teletherapy machine or LENAC or proton therapy is a costly affair. So government has to take the action and fulfill the criteria which has been decided by IA or WHO. 450 cancer patients should have one teletherapy machine. So we are lacking radiation facility very much in North India. South India a little bit better and Maharashtra is little bit better, but North India is require very much teletherapy machine. I think 230 272 machine is required according to the population we are catering. So I think government has to take the action and provide the fund for government institution to purchase the machine and establish their facility at district level. As central government is emphasizing the medical college, opening the medical college at every district level. So after opening the medical college, they should provide the facility to treat cancer also. They should establish the department of radiotherapy and create the jobs for the radiation oncologist, radiation physicist, and radiation technicians. So only
Um, Hi, ma'am. Are you there?
you got it or not?
Yeah, I think the last bit, we lost you on the last bit. Apart from that, we heard from you about how the government should support the government institutions. So I think we got you till there.
Establishment of department at every medical college.
Correct, correct. So I think with that, we will take our next question to you, Dr. Preetam, that how can large institutional networks be better utilized to reduce patient load imbalance and improve timely access to care?
Okay. Um, if you ask me with my personal experience, see, in our country now, we don't, we are not lacking the capacity problem. We have enough number of institutes at a larger level with the regional centers, apex centers working efficiently. What we are lacking is the poor distribution and networking problem. And as a result of which that equitable access are not being provided to our patients. Now, at a larger institutes, I always feel that the cancer care should be at a tertiary and the regional centers where all the departments are functioning under one roof. That gives the best outcome to the patient. An institute with a very high experience and high volume patient center create a significant difference. So when we strengthen this coordination and network, and the follow-ups and some of the part of the treatment can be decentralized with a strong coordination and communication between the peripheral centers and the larger institutes. It is important to enhance these centers in tier 2 and tier 3 cities in the rural areas. Also, it is important to have tele-oncology centers or the online tumor board discussions where the patients don't have to travel all the way from the periphery center to the main regional centers if it can be discussed through the online having a tumor board discussion and can be initiated. Uh, Increased penetration of the insurances and government schemes are also of paramount importance because uh, providing the facility and treatment care within the vicinity of the home is also essential. And many times patients may not be able to procure that treatment into the nearby because of the lack of these schemes availability. So I believe it is not a capacity problem. It's more of strengthening the coordination and networking and decentralizing with a standard protocol, which is followed, universally across the country, thereby strengthening these institutions, uh, providing the best outcomes to the patients.
Correct. I think I will take my next question to you, Dr. Satish, that what operational or structural changes can high volume private centers implement to manage increasing patient demand without compromising the outcomes?
So I think that you see many of the institutes uh, they have a long waiting time, and because of that, like we see this few center of excellences where where I think instead of doing the basic cases, there should be a proper referral center where say if the lung cancer is there, so they should be dealing with all the rare cases rather than the regular cases. Like recently, many a time we see a operable lung cancer which goes to a particular center, and then a lot of waiting time is there, and then such the CT scan will take 1 month or 1.5 month. The PET scan dates are 2 months. So in that case, if the patient can be operated where it can be when they can be operated, so their stage increases, and many times patients who can be cured, they are they move to stage 4. So I think a proper selection of the cases where volunteers will be required, where MBBS or a person who's trained in oncology, they can screen out these cases where the a particular expertise is not required. And similarly, they can tie up with the nearby centers where the CT scan or PET scan they can be done on time, and at least a, a fair opinion about whether this disease can be treated at their regional places or not. So I think
Correct.
the NGOs have a work to play here, and the proper counseling of the patients.
Correct. I think I'll take my next question to you, Dr. Divya, that what would be your purview on this point that Dr. Satish just made, and also along with that, among awareness, screening, patient navigation, and financial support, which intervention has shown the most measurable impact on improving the access?
Um, Thank you so much for the question. It's a very important one. So, what consistently makes the biggest difference in having a mechanism that ensures the patient doesn't get lost in the system is very, very critical. Even when awareness exists and services are available, patients often struggle with next steps, where to go, how to navigate referrals, how to manage logistical and financial barriers. So, structured support, especially patient navigation, has been the strongest and most immediate impact in addressing this gap, in my experience. And it improves linkages to diagnosis and treatment, it reduces delays and strengthens adherence to treatment. And in many, many ways, it acts as a connector across the continuum. So, like Dr. Satish was saying, that we need decentralized way of taking this, and also creating some sort of filter where the required treatment is delivered to patient in need. So the continuum has to be the continuity of care is while upstream intervention, these are very critical, but we have to ensure continuity of care, which will ultimately drive the measurable improvement in access, and also will benefit the patient who require those treatment, while ensuring that the system also plays a very important role in the structure of it.
Just to give example,
Correct.
Divya, I'll agree with Divya. Ki the navigation is more important. Today only, I got a patient news that one of my lung cancer patient expired. She was ALK positive and she was about to receive a drug lorlatinib, for which we got through Tata Trust Foundation. We got 15 lakhs of approval. But the attendant which was there with her, she didn't know how to get a drug, and for 1 month she was without a drug, thinking that some other way of getting a drug is there. So today, when we missed a patient with funds, with everything there, I think there was nobody to guide her, and we lost her.
Correct. I
Right,
think
that's often the case, sir. Even when in my day-to-day field interactions, we usually we lose patients because they don't know where to go, what to do, and sometimes their family members are also engaged in their day-to-day life. They do not want to invest their time in going for these important checkups and then taking to the next step. So the gap is very significant, and you are right. NGOs need to step up and do something about addressing this gap here.
And also, we
I
need
think
to
a
have
lot
this
of handholding and personalized care is required here.
and
There
I
has to
at
be
the
think
times
somebody
I
who
feel,
have to hold the hands.
yeah.
and at the times I feel ki the local navigators are the most useful when the patient, they understand this patient language, they understand their needs, and if you get a local navigator, nothing like that.
Absolutely.
I think through session by session, this is the common thing that comes up. And since at this forum, which we have created here at VOH, we have tried to bring some representation from the patient advocacy and a public health perspective. So for the past few sessions, we have been having representations from We Care Foundation and organizations like this. And they have been telling us that how just the navigation part is helping altogether the entire lung cancer care pathway. So I think it is a very relevant point that has been raised through these sessions, and there should be some conversation and some discussion and some real outcome out of it. So I mean, keeping that in mind and taking our discussion forward, I'll take my next question to you, Dr. Tejinder, that which clinical outcome indicator should be prioritized nationally to better reflect real progress in lung cancer care, and why?
So parameters should be looking at a very clear definition that you are looking at a survival. Now the issue that is a gold standard parameter. You are looking at a survival, but with a good quality of life. Like I think that is a parameter which, as a clinician, we look into it. We look into this as a gold standard where the survival should be the main detour. Remember, when we treat any cancer, we treat them in a two simple aspect. One is called curative intent, where the goal is to cure the patient, but that happens only for certain group of patients, especially early stage. But for a patient who is metastatic stage 4, your goal is mainly, we use a word called palliative treatment, which has been put up in a different way by way of prolonging life. But can a stage 4 cancer can get cured is a big question which we are still trying to answer. But our goal is for sure to make it a disease which is like diabetes, where you're able to control it. So cure should be the ultimate goal for early stage. That's the reason why we always say that early diagnosis probability of cure is there. But even for a patient who is stage 4, lung cancer treatment has made a lot of changes. There was a time when the only option used to be chemotherapy. Now we have precision based, personalized based therapies which are there, where the challenge is still the cost. Like I think Satish also mentioned about a drug called 𝗟𝘂𝗏, but the issue starts over there because right now they do not have a biosimilar, or they do not have a Indian made drugs. Cost is still on the higher side, but I think there are options available. uh, Problem with the option is that it takes time for the procedure to navigate. So I think let us not go into that area because it's a area which will take time. Like I'm very clear with one point is that India has resources for everything. You are able to treat poor patient, you are able to treat rich patient. Like I said, 20 years back these issues used to be very gross. We are now moving to a area where government is also trying to help. There are a lot of NGOs which are trying to help, but certain areas, the application takes so much of time that it is very time consuming. So I think we are far better than what we were previously by way of the management, but financial part also we have improved a lot. We have gone away from the heavy side effect of the chemotherapy to more precision based. Lung cancer is one disease where around 80% patient they will have some kind of precision based, personalized based therapy where the survival is excellent. So I think cure should be the goal. In a palliative setting, survival should be the goal.
Correct. I will take my next question to you, Dr. Seema, that what policy or system level changes are needed to ensure timely initiation and completion of treatment, which becomes standard practice?
I think we should start the training of radiologist, pulmonologist, and pathologist. To at least they should get the biopsy at their center at district level or PSC or CSC level, so that the diagnosis can be made early. And for the treatment, if they diagnose the patient and they communicate with the patient for the higher center treatment, the patient will get the treatment on time, and they will get the patient will get the overall better survival and better quality of life. And second thing, at the treatment level, government should provide the accommodation and subsidize food and travel allowance. Many things they require, so small things the government should take care of that. And as the idea given by the Dr. Satish, by the help of NGO, we can counsel the patient on psychological counseling and the result of the treatment. What are the side effect of the treatment, they can be explained by the NGOs or a psychological counselor, so the patient will get the counseled and satisfied with the treatment, with the procedure, with their comfort level of living. I think these measures can be taken for the betterment of the treatment, and patients should get the completion of treatment in a better way.
Correct. I think that shows a very relevant and a lot of emphasis on the government side, and I think that is being taken care, and there is some progress in that direction. So yeah, with that, I mean, I'll take my next question to you, Dr. Preetam, that how can continuity of care be ensured when patients transition between different healthcare providers or systems?
Uh, I think it's a very important question. I would like to come to my original point that delivering the healthcare, especially in cancer care, is a very complex phenomenon, and there's a lot of fear within the patient when the news is broken that is suffering from a cancer, and the entire healthcare journey is fragmented. So it's important that the right from the referral system to the diagnosis, staging, and the treatment happens at a single centers where patients don't have to move from one place to another place and get the system oriented, which takes a lot of time. Having the expertise under one roof makes a huge difference in the clinical outcomes. Also, it's equally important to strengthen the coordination, having an effective communication with the patient and the family, boosting the confidence within them that we live in an era where the survival of the patient has significantly improved with the best chance of cures in early stage and in advanced stage. A good palliative treatment is of paramount importance. So, during this journey and the transition to reduce the dropouts, it's important that a good personalized care with handholding and taking care of the financial aspects is of paramount importance. So, at multiple levels, we need to uh, take care of all the aspects, to make sure that the entire journey of a patient in this lung cancer care is smooth, right from the diagnosis, treatment, and the palliative care.
Correct. So, with that, I would like to take my next question to you, Dr. Satish, that what role should institutional accountability and clinical audits play in ensuring consistent quality of care across centers?
So many times we have seen that even with the best centers in the country, we don't have a common protocol. Suppose we have seen somebody using low dose nivolumab immunotherapy in gallbladder cancer, in somebody will use 40 mg, somebody will use 20 mg. Like in breast cancer, we have some used somebody using in 1 in 3 cycle. So that creates a lot of confusion, and most of this medicines, most of this regimens, many a times are not standardized. So I think the institution across the country, at least which are the center of excellence, they should come together and they should stick for a particular cancer for a particular protocols, and that will create a lot of confusion. And also, it will help the government to form a common program like in Ayushman Bharat. Say we have many drugs which is available, which is 40,000, 50,000 rupees, and the package is like 15,000 per chemotherapy cycle. At the same time, we have a proof, we have evidence where the low dose nivolumab can work. And with coming of Indian generic, I think it will be very much under the ambit of Ayushman Bharat. So if the all institutions come together, so first thing is many of the unaccessible drugs, which is not accessible to the Ayushman patients, they will be accessible, and then we can form a standard protocol all over the country, at least across the center of excellences. Second thing, the audit will also help. Many of the foreign countries, they share a practice of a common vial, where if somebody is not affording, we can share the vial, but that doesn't happen in our country. Many logistic and the social issues. So coming forward, if we have a common program or a common protocol, we can follow the same thing in at least the bigger institutes.
Correct. I'll take my next question to you, Dr. Divya, that how can outcome data be effectively translated into actionable insights that influence both policy decisions and clinical practice?
So we often see that there is a missing. We need a shift from reporting numbers to actually using them to drive decisions. So, for this data to be meaningful, it needs to focus on outcomes such as timelines. So, from screening to treatment initiation, what stage the diagnosis was made, the completion of the care, and not just volume based indicators. I think Dr. Preetam also rightly said this at the very start of the session that the patient's experience should be very smooth. The admission should happen at an early stage, and the entire process till the end of the completion of the care should be very smooth for a patient. And that should that action has to be followed from the insight that we drive from the data. And equally important is creating regular feedback loops where the data is reviewed and used for course correction at both program and facility levels. And it should be used to take informed decisions in real time and not retrospectively, which often happens when we see it in today's time. And finally, there has to be a clear ownership, which I think when gaps are identified, accountability needs to be defined. So that action follows the insight. So when data starts influencing both clinical practice and policy, you see tangible and scalable outcomes. And this is the goal that we want to achieve with this shift in perspective here.
Correct. I think it was a very insightful discussion about strengthening a lung cancer care pathway. And with this, we come to an end of today's discussion. And thank you to all our panelists for taking out time and joining this session today. It was a wonderful conversation and very insightful for all our listeners as well. All the inputs that we have had from today's discussion will surely help to strengthen the lung cancer care pathway in the coming future. So, thank you so much for joining.
Thank you.
Thank you. Thank you, everyone.
Thank you. Thank you so much.